Hello everybody, my name is Dr. Chiwewa Ronald. I'm a general surgeon with a special interest in trauma, and today let's discuss abdominal trauma in the context of trauma cases. I would like to recognize Yale Department of Surgery, the UCSF Department of Surgery, the Laura Case Trust, Mulago National Hospital, and GPAS for enabling all these works happen and compiling these presentation. So by the time we end, we should be able to have appreciated the global context of abdominal trauma and epidemiology, blunt and penetrating trauma, as well as pelvic trauma. We should have an idea about the first scan. We should have discussed management strategies and ideal treatment. And we should also highlight adaptations for resource-limited settings or context-specific treatment, and we should have a case for discussion. So globally, abdominal injuries are responsible for about 20% of all trauma-related deaths, and unfortunately, they are frequently missed. Apparently, isolated injuries may have other associated injuries. For example, splenic injuries have a 10% chance of concurrent diaphragmatic injuries or small bowel injuries, and in the event that there's a fall from a height, bowel and bladder lacerations can also occur, as well as bleeding in the retroperitoneum. In situations where there's a seatbelt sign, 23% of patients usually will have tears in the mesentery or the liver or the duodenum or even the jejunum. So this picture is intended to help you appreciate the regions of the abdomen as you anticipate the associated injuries. As you can see in the epigastrium, we have the liver, the stomach, and retroperitoneally maybe the pancreas and the duodenum. In the right hypochondrium, we have the liver. To the left side, we have predominantly the stomach and the spleen. In the umbilical area, we have intestines, predominantly the jejunum. Right and left lumbar, we have the kidneys and the iliac fossa. We have other organs, as is demonstrated in that picture. So the purpose of this is to help you appreciate which organs could be damaged if you have abdominal trauma. So most injuries for abdominal trauma are blunt injuries, but we can have penetrating injuries. So for the blunt injuries, 30% of the times the spleen is involved, 25% of the times the liver is involved, 20% of the times we have involvement of the kidney, and abdominal vessels are less commonly involved in blunt abdominal injuries. Usually the patterns, when somebody has a seatbelt sign, the lap and the sash, and we shall see this demonstrated in a picture later on, they could more commonly have jejunal perforations. When it's the lap belt only, duodenal perforations. If it is a side impact, you could have injuries to the liver or the spleen. Sports-related injuries like punches and in boxing, splenic lacerations, bicycle or handlebar injuries by police officers onto an abdomen of a criminal. They have pancreatic injuries and jejunal injuries, and we have incidences where somebody may be horned by the horns of a cow or the horns of a bicycle, and these are usually associated with small bowel perforations. So usually what we do in the abdominal assessment for a patient with abdominal trauma, we must always factor in the mechanism of injury, we must always factor in the force involved, we must always factor in the location of the injury, and we must factor in the hemodynamic status of this individual. So remember, we have two types of trauma: blunt trauma and abdominal trauma. So for blunt injuries, Assess for the occurrence of associated abdominal organ injury. We saw the picture highlighting exactly which organs exist where. And the injury may be due to seatbelt use, sports injuries, or innocent scenarios such as the handlebar injury, as you can see demonstrated in the picture on the slide. Now, we have a typical picture here of a seatbelt sign, okay? And you can guess which injuries could be involved, right from the chest and particularly in the abdomen. You can easily tell that the lap belt sign crossing the abdomen could involve from the stomach, the pancreas, and to the intestines. So looking out for these signs is important, and they can exist especially in the more light-skinned individuals. It could help you anticipate a number of injuries in the abdomen. So the other type of trauma that could occur to the abdomen, penetrating abdominal trauma, usually many of these are stab wounds, and the injury is generally confined to the tract of the weapon at the wounding. However, you may have unique penetrating abdominal trauma injuries, like gunshot wounds. When you have gunshot wounds or missile injuries, the injuries will depend on the type of weapon used. For example, a pistol could give you a different injury from a shotgun, depending on the trajectory and the amount of missiles being released from the bullet. The size of the projectile also matters, and the distance from the assailant matters as well. When you have high energy rifles, such as military weapons, these are more dangerous even because they produce cavitation that results in a wide tract of destruction and contamination. So what do we do in the initial assessment of abdominal trauma? Usually we follow the ATLS arrangement like is the case for all other trauma patients. We do a primary survey, we identify life-threatening injuries and resuscitate immediately. Then we can go to a secondary survey. Then we can do a diagnostic evaluation and institute definitive care. So in the primary survey, we usually look at the airway, cervical spine protection, breathing and ventilation, saturation and control of hemorrhage, disability, which usually refers to the mental state, and then we expose the patient without causing hypothermia. All these avenues go with adjuncts or situations that intervene. We used to intervene. So in the abdominal assessment, usually it is the C that is affected, and we want to assess quickly the hemodynamic instability and try to correct it as soon as possible. We identify the obvious need for surgical intervention. For example, if you have penetrating trauma or evisceration of abdominal contents, and we sort this immediately. In the secondary survey for the abdominal assessment, we usually want to classify the injury. We want more specifically to call it either blunt or penetrating or both, and we do this as we inspect, palpate, percuss, and auscultate the abdomen. Please remember that the location of the injury is very key in helping you determine the extent of the injury. On inspection, we could look for abrasions, bruising, the lap belt or the seat belt sign, retroperitoneal hemorrhage. For example, we could have ecchymosis in the periumbilical area, which is what they call a Cullen sign, or the flanks, which is what we call the Gray Turner sign. It is very important to inspect the genitalium and the perineum for any ecchymosis as well. In palpation, we palpate for fullness. The abdomen could be distended, which could indicate probably there is fluid in the peritoneal cavity, pointing to hemorrhage. There could be crepitations in the lower rib cage, which could point to hepatic or splenic injuries. The patient may have tenderness and rebound tenderness, so features of peritonism, which could demonstrate that there is a ruptured viscus with leakage. It is always very important in palpation to end with a rectal and vaginal exam, so that you can assess if there's penetrating injury or if there's involvement in areas as well. So a thorough clinical exam of the abdomen may not be enough for you to approximate 50% of, especially in blunt abdominal trauma. Sometimes there could be missed injuries. And always have a high index of suspicion for occult injury in any of the following. For example, if there is abdominal tenderness or rebound tenderness, if the patient's abdomen is rigid, if the patient has a seatbelt marking, always have a high index of suspicion that you missed out an injury. When you inspect the abdomen, expose the patient from the lower chest to the upper thighs. Always inspect the back, especially where you have missile injuries, gunshot wounds. Inspect the back for entry and exit wounds. Furthermore, as you move on to palpate and percuss the abdomen, if you have guarding, and this could be voluntary or involuntary, these point to peritoneal irritation, and you should be seen to think of abdominal injuries. On superficial palpation, deep palpation, you could get rebound tenderness. Look out for increased tympany on percussion, which could indicate pneumoperitoneum or leakage of air into the peritoneal cavity that could indicate usually a ruptured abdominal viscera like intestine. It is useful to detect an enlarged solid mass or a distended bladder as well, because the distended bladder could point for obstruction further down. So for the abdominal assessment again, with palpation, after palpation you have auscultation. It is rarely helpful in trauma assessment. Usually it's the inspection, palpation and percussion that is more helpful. So the adjuncts or certain investigations and procedures you can do to help tease out abdominal trauma injuries. One of them is a chest x-ray. Okay, we always do a trauma series, chest x-ray, pelvic x-ray and the head CT scan nowadays, but an upright abdominal x-ray that demonstrates free air under the right hemidiaphragm could be able to indicate that there is rupture of a hollow viscus, usually an intestine. So if you have intestinal perforations, this is how you may be able to tease out and make sure that there is an injury. So the ultrasound scan. Now, a typical ultrasound scan for abdominal trauma is what we call the first scan, the focused assessment for sonography with sonography in trauma with an extended beat, which is what they call the E-FAST. Now, it's not common to have this scan probably present in all areas, but we must emphasize that this ultrasound scan, routinely available in all centers and particularly maternity wings, can be deployed for this fashion if you have the skill and knowledge to tease out where fluid in the cavity may be. So the E stands for extended, and the first is focused assessment with sonography in trauma. It is a rapid, non-invasive, accurate, not expensive test that can be repeated multiple times. A positive first exam, which usually demonstrates leakage of fluid into the peritoneal cavity, and this fluid is usually blood, is helpful and reliable if you have a hemodynamically unstable patient with blunt abdominal trauma. However, if the first scan is negative or equivocal, it may be followed by what we call a diagnostic peritoneal lavage, DPL, or in situations which allow even a CT scan. So let's look at these tests. For identifying a hemoperitoneum in blunt abdominal trauma, a first scan has a sensitivity of between 76 and 90% and a specificity of 95 to 100%. It can detect a total amount of fluid of up to 250 cc's and up to 100 cc's in the pouch of Morrison. So where do we scan? We have about 4 windows in the non-extended version. We have a subxiphoid window, which is indicated as number 1 there. We have a window in the right upper quadrant, which is indicated in number 2 there. We have a window in the left upper quadrant, which is indicated in number 3, and a window in the suprapubic area, which is indicated as number 4 on your slide. So where do we scan? Again, the right upper quadrant, the left upper quadrant, below the xiphoid, the suprapubic area, and in the extended version, the 3rd to 4th intercostal spaces in the mid-clavicular line, and the 3rd to 4th intercostal spaces on both sides in the mid-clavicular line. So for the views in the right upper quadrant, we extend our probe in the mid-axillary line. Usually we look at the probe cavity as well. We look below the diaphragm. We look in the hepatorenal recess, that gap between the liver and the right kidney, which is what we call the Morrison's pouch. And inferior there, we look at the inferior part of the kidney all the way to the right paracolic gutter. These are areas where fluid can collect. In the left upper quadrant, similarly, we look in the pleural cavity, we look below the diaphragm or the perisplenic space. We look through the splenorenal recess. This is a gap between the spleen and the left kidney, and we look at the inferior pole of the left kidney as well as the left paracolic gutter. These are areas where fluid can collect. In the subxiphoid window, we want usually to look at the heart chambers and the pericardial space, the space in which the heart plays. We could have a collection of fluid there that could cause us a pericardial tamponade, and we can tease this out with a fast scan. In the suprapubic view, we look at the retrovesical space, the space behind the bladder, and the retrouterine space in women, which is the pouch of Douglas. So these pictures are intended to demonstrate for you the spaces, as you can appreciate in that slide. There is a subxiphoid view, a right upper quadrant view, a left upper quadrant view, and a suprapubic view. These are intended for you to appreciate which areas can be scanned. So this is a sonographic appearance of what you could see on your screen with the first scan. The first picture demonstrates for you there the liver and the Morrison's pouch, the gap between the liver and the right kidney. The second picture to your immediate right will demonstrate the pericardial window or the subxiphoid window, and you can see the ventricles of the heart and the pleural space there. The third view demonstrates the splenorenal recess, and the final one demonstrates the retropubic space. So the CT scan, we could discuss about a CT scan and its role in the hemodynamically unstable patient. It's very important because it can be non-invasive. So if available, consider it in the hemodynamically unstable patient. But principally, your clinical treatment should be able to drive you either to make an operative decision or not. So it can reliably diagnose solid organ injuries, for example, liver and splenic lacerations, and grade them for you properly. And it can help us evaluate the retroperitoneum. But it is not as sensitive and it's not as specific for whole viscous injuries. For example, if you have perforations of the small intestines and injuries to the mesentery. Diagnostic peritoneal lavage may be more specific and more sensitive for these ones. Why? It is a rarely performed procedure, especially after the advent of the first scan. But when a first scan is not available, for example in the village, and a CT scan is not available, you could deploy diagnostic peritoneal lavage to help you make a diagnosis. Or in mass casualty situations where you can't keep scanning individual after individual, you could use this DPL procedure. So basically, it is more or less a mini laparotomy. You must place a lavage catheter, which could be a Foley's catheter, into the peritoneal cavity, and you direct it towards the pelvis. And then you have to infuse at least a liter of fluid into the pelvis, and then aspirate it and take it for microbiology in the laboratory. If blood is present, then the test is positive. Usually if negative, then the effluent is sent further to the lab to look for red blood cells, white blood cells, or sources of infection, particles of food, or bile, or bacteria. This picture generally demonstrates what we do. We want to hold the skin on the anterior abdominal wall anteriorly, so as to direct this catheter into the peritoneal cavity at an angle of about 45 degrees to the anterior abdominal wall, introduce the fluid, and then get out the fluid and seek it for analysis. The DPL for a positive exam, initial aspiration of gross blood, that gives us a positive exam if it's more than 10 mils, or if we initially aspirate bile, vegetable fiber, or contents of the gastrointestinal tract. If nothing is aspirated, usually infuse warm saline, a liter into the peritoneum, allow it to mix, or drain by cavity. By gravity, usually we may have to shake the patient's abdomen to mix up these contents. And it will be positive if you see gross blood, bile, vegetable fiber. It will be positive if in the lab they can find more than 100,000 red blood cells per milliliter, or more than 500 white blood cells. It will be positive if they can find more than 175 units of amylase per milliliter to indicate pancreatic damage, or if they can find intestinal contents and bacteria on gram stain. So this table, you could take your time and study it. It generally compares for us the first scan, the DPL, and the CT scan in terms of repeatability, sensitivity, specificity, and the kind. But you'll just discover that for all these tests, the more readily available, non-invasive, cheap, easily repeatable test remains the first scan. So it is advised that you increasingly acquaint yourself with skill to be familiar with the first scan. So this slide helps us repeat, probably it helps us highlight a full blood count and other laboratory tests that you may need in analysis for a patient with blunt abdominal trauma. An elevated white cell count may point towards gastrointestinal perforation. A urinalysis, when you see blood in urine, hematuria, it may be indicative of a blood or a kidney injury. And sometimes small subtle bladder ruptures or bladder injuries may not have gross hematuria, blood in urine, and some of them it may even be microscopic. So it's important to evaluate also genitourinary tract injuries, but this could always come later after the essential procedures have been done to save life. And usually a CT scan with contrast may be used to assess the integrity of the kidney or the liver. For the urethra and the bladder, a retrograde cystourethrogram could be used to tell if you have urethral injuries. For example, this picture shows you a retrograde urethrogram. We have extravasation of contrast from the bladder, meaning that there are bladder injuries. So for patients with hemoperitoneum in the initial management, as seen from the ultrasound scan, it's important that the patient who is not hemodynamically stable receive surgery. For patients that are not hemodynamically unstable, surgery may not necessarily be indicated despite injuries demonstrated on the investigations shown above. Always seek an early surgical consult so the surgeon can make a deduction between whether to operate or not. If you are a lone individual in the village, please improvise accordingly using the information given to you in the previous slides and the first scan and your clinical acumen, and decide whether to do a laparotomy or not. And please remember that lack of a CT scan does not and should not lower the threshold for exploratory laparotomy. Okay. For whole organ injuries, the common causes are usually sudden blows, to the abdomen, and they cause sudden abdominal pain with distension, vomiting, and fever. With CD abdominal scan may demonstrate peritoneal signs, and this could manifest at any one time between 6 hours to 12 hours after injury, and you could see rapidly distending gaseous abdomen, fever, and other signs of features of intestinal obstruction. These will definitely warrant surgical evaluation. For other solid organ injuries, abdominal ultrasound scan may not be as sensitive for diagnosing them. If possible, and you can have access, use a CT scan. If inconclusive and there's free peritoneal fluid, please reassess hemodynamic instability of the patient and determine whether you need a laparotomy. For injuries of organs in the retroperitoneum, like the kidney, like the duodenum, if you have trauma, either penetrating or blunt, indicating involvement of the flanks, think of kidney injuries. Retroperitoneal hematomas may easily be diagnosed by a skilled operator using an ultrasound scan. Always repeat the ultrasound scan severally so you can discover if a patient warrants exploration, especially if they have an expanding retroperitoneal hematoma. In the initial assessment and management, always focus on the C for the abdominal exam in the primary survey, with the mindset of finding bleeding and stopping the cause of bleeding, whether or not it involves a laparotomy. The patient should have a 16-gauge cannula or the largest available bore cannula, and activate massive transfusion protocols when necessary. So this picture demonstrates a patient with penetrating trauma. You can imagine the organs there that could be involved. Always never dislodge a penetrating organ until theater. Okay, penetrating trauma, gunshot wounds, quite common, stab wounds, and sometimes we have deliberate self-harm. Every time you have peritonism, free air on the X-ray, evisceration of gut, penetrating abdominal trauma of any kind, and bleeding following penetrating trauma, you will need a laparotomy. So for pelvic trauma, let's quickly look at it. Sometimes we have pelvic trauma. You may have to subject the patient to a pelvic stability test. Please do it once, not severally. And in the event that patients have open book fractures, put a pelvic binder, and when stable, send them for a CT scan. If they remain unstable, they may need rapid surgery. This picture demonstrates to you an exotic pelvic binder, and if not available, a local available pelvic binder that you can use even in the village by fashioning a bed sheet around the pelvis. So there's a small case for you to ponder about. Think about a 20-year-old male who was thrown off his bicycle and he hit his abdomen on his handlebars. He has a GCS of 15, a blood pressure of 105/8, and a heart rate of 112, with a respiratory rate of 18. What are your initial steps in management, and what would your priorities be?